Guys, hi, good evening. How are you? How are you all? Yeah, hi, Vanilla. How are you? I hope my voice is clear. Am I audible? Am I audible? Yes. Hi, Dr. Samrat. Hi, how are you? I hope you're all good. Let's have a great case discussion today. Good. Thank you. Thank you, Dr. Samrat. Thank you, Dr. Vanilla. So yeah, me too. Thank you. Me too. Thank you so much. Right. So we'll start with today's session, buddy. So today's session is going to be, as we know, it's going to be Clinical Thursday. So every Thursday, we'll be discussing clinical scenario-based questions. Usually, it's going to be like in pharmacology-based scenarios, is going to be drug-induced adverse drug reactions. But here, today, we're going to be discussing it in a little bit deeper perspective. It's going to be a newer case scenario. Let's look into that. Let's just dive into this case, today's case scenario, guys. A 65-year-old male presented with just give me 1 minute. Yeah. A 65-year-old male presented to the casualty with complaints of muscle weakness in the extremities of both limbs and sometimes causing muscle cramps for the past 2 days. The presenting complaint is going to be muscle weakness in the extremities of both the limbs, and there are occasional on and off muscle cramps are there for the past 2 days. Moving on to the past history. Past history, the patient was suffering from diarrhea for the past 3 days, and there is no episode of diarrhea since yesterday morning. He didn't take any treatment for his diarrhea. He was suffering from diarrhea for the past 3 days, but from yesterday morning, there was no diarrhea. And most importantly, he didn't take any of the drugs which is there. The next one, medical history or medication history. The patient is a known hypertensive for the past 10 years under hydrochlorothiazide. The patient is a known hypertensive for the past 10 years under hydrochlorothiazide, 25 milligram monotherapy. We all know that hydrochlorothiazide is currently not the first line of therapy for any type of hypertension, because AC inhibitor or ARB would be the first drug of choice. But if the patient is not responding, we can add diuretics for this patient. But unfortunately, this patient has been started long before with hydrochlorothiazide, and the patient is currently on treatment with the same HCT therapy. Known asthmatic under treatment with salbutamol. MDI means meter dose inhaler. Usually using it as on need basis. Whenever it's necessary, the patient is going to be using that. Last used 2 puffs yesterday, early morning after an episode of SOB. SOB means shortness of breath. SOB means shortness of breath. Moving on to the next one. Personal history, the patient is a known alcoholic for the past 20 years. The patient is a known alcoholic for the past 20 years. Last intake was 4 days before, because as he was suffering from diarrhea, he didn't take alcohol for the past 3 days. What might be the provisional diagnosis in this case, buddy? So with this knowledge which we have, based on the previous history and based on the present history, the patient is the patient has presented with complaints of muscle weakness. That was his presenting complaint. So we have to come across the different causes of these types of muscle weakness which can be there for this patient. So what kind of muscle weakness the patient is having? He's having a peripheral muscle weakness, and that's what is the patient has presented with. Notable points: patient as a known alcoholic. He didn't take alcohol for the past 3 days. The patient is a known hypertensive under hydrochlorothiazide, known asthmatic taking salbutamol, and the patient has been suffering from diarrhea. And since yesterday morning, diarrhea has stopped, but patient was suffering from diarrhea for the past 3 days. These are the take-home points from there. From this, what are the provisional diagnoses which we can come across, and what might be the future investigations you might be moving upon? Based on the scenario which we currently have, the differential diagnosis includes point number 1, The patient is having muscle weakness in the periphery. Point number one, can it be a brainstem lesion? Can it be a brainstem lesion? Yes, it might be a brainstem lesion, but we have to make sure whether there is any additional cranial nerve involvement or not. Is there any cranial nerve involvement for this patient? No, there is no involvement of cranial nerves. There is no involvement of cranial nerves in this patient, which rules out brainstem lesions. Number two, can it be an inflammation in the spinal cord? Yeah, most commonly, I think majority of the students, when I just put across, majority come across with the same diagnosis. What if there is an inflammation which is there in the spinal cord, like disc prolapse or any inflammation which is there? Of course, there is more chances of muscle weakness, which might be there in the periphery. But most importantly, whenever the nerve is getting compressed, we might also expect additional sensory signs too. In this patient, is there any sensory symptoms? No. Here comes the answer. There is no sensory symptoms associated with any of these conditions. Bladder, is it going to be normal or abnormal? Bladder abnormality, it might be a query of whether the patient might be having a spinal cord inflammation. The bladder is normal. Yes, the bladder is normal, which rules out any inflammation which is going to be there in the spinal cord. So MRI or CT currently is not necessary for this patient. Moving on to the next one. Is it a peripheral nerve disease? What are those peripheral nerve diseases? What are those peripheral nerve? Good evening. I think I got a message here. Good evening. Good evening. Thank you. So peripheral nerve diseases, which includes Guillain-Barré syndrome, GBS, Guillain-Barré syndrome. But what is the most important feature of Guillain-Barré syndrome when compared to this particular patient is we have to look at the reflexes, DTR, deep tendon reflexes. Please note that in terms of Guillain-Barré syndrome, there is going to be reflexes is going to be either decreased or the reflexes is going to be absent. In this patient, there is no issues like that. The reflexes are normal. The DTR is going to be normal in this patient, which rules out brain stimulations or spinal cord issues or peripheral neuron diseases. All these three has been ruled out. Most importantly, remember that this patient is presenting with muscle weakness. Moving to the next differential diagnosis which we can come across. The next DD includes point number one. Can it be myasthenia? Can it be myasthenia? Can I get some answers here? Can it be myasthenia? I think it will be a little bit difficult, buddies. The point is, yes, there is a possibility of myasthenia gravis, but myasthenia gravis is not solely associated with muscle weakness, especially in the periphery. There is going to be a generalized weakness, which can be most commonly seen in peripheral areas too. But apart from that, there might be other weaknesses like there might be ptosis, which is associated. There might be dysarthria or dysphagia, which is along with the usual symptoms that the patient is presenting. There might be fluctuation of weakness. There might be ups and downs of the weakness of muscles within a single day itself. So we have associated weakness, and there might be a fluctuation of weakness also, which can be expected. Now, this is not seen in this patient, guys. Clear? Moving on to the next differential diagnosis. Can it be botulism? Botulism, there is more chances of botulism. Why? Because food poisoning, especially botulism, usually manifests with prodromal symptoms like vomiting or diarrhea or lethargy or fever, followed by muscle weakness. Remember that this patient was suffering from diarrhea for the past 3 days, followed by muscle weakness, which the patient has developed. It is more oriented towards botulism, but I will say that this patient is not actually suffering from botulism. Why? Because the symptomatology of the muscle weakness is a little bit different. This patient has got peripheral muscle weakness first, whereas botulism, that is associated with food poisoning. Botulism, there is going to be descending weakness. The botulism, it's going to be mostly associated with the descending weakness, which means trunk muscles will be involved first, followed by the peripheral muscles. That is going to be classically seen with botulism, which is not seen in this patient. This patient trunks remains normal. Only the peripheral areas are landing up in weaknesses. Now comes the last and the most important differential diagnosis. So what are the things which we have ruled out? The patient has got no brainstem abnormalities. Why? No cranial nerve involvement. The patient's sensory system is normal, which means there is no spinal cord inflammation. The patient's reflexes are normal, which means it's not GBS, or because basically it's not going to be GBS. Number 4, the patient's, there is no fluctuation in the weaknesses and the weakness is not progressing beyond that, which means it's not going to be myasthenia. And the weakness is not starting from central towards periphery, which means it is not going to be botulism. What might be the differential diagnosis? The next one, can it be hypokalemia? We used to call them as hypokalemic myopathy. There might be a possibility of it. To understand this, we have to know the serum potassium levels. What are the serum potassium levels? When we come across, when we took the investigation for this patient regarding the serum potassium levels, we came out that the potassium levels are actually 2.3 milliequivalents per liter. The potassium levels are actually 2.3 milliequivalents per liter, which explains that the patient is actually suffering from hypokalemia. Now, so what exactly is this case? We can actually cornerize towards a particular diagnosis based on the investigations which we have taken, that the patient might be suffering from hypokalemic myopathy. But anyhow, we have to just go back to the history and try to find any links between this hypokalemia and the drugs which the patient is actually taking. So what was the history again? What was the case scenario here, buddies? The patient was suffering from muscle weakness in the extremities of both limbs, sometimes causing muscle cramps for the past 2 days. The patient was suffering from diarrhea. This is the first important point. There is more chances of hypokalemia because of diarrhea. Mostly this hypokalemia can be seen in terms of chronic diarrhea for more than 3 weeks of duration. But here, this patient might also land up in diarrhea. Why? Because he has got lots of additive informations related to hypokalemia. We'll look into it one by one. Medication history, the patient is a known hypertensive for the past 10 years, now currently under hydrochlorothiazide. Thiazide diuretics. What are the adverse effects of thiazide diuretics? There might be a possibility of hypokalemia there. The next one. The patient is a known asthmatic under treatment with salbutamol. MDI. What is MDI? Metered dose inhaler. The patient is currently under salbutamol metered dose inhaler, which is actually a beta-2 agonistic agent. There is a possibility of hypokalemia with that drug. No need to worry about it. I'll be explaining the mechanism of how each and every drug is going to be inducing hypokalemia in any patients. And most importantly, the patient is not taking salbutamol regularly. The patient is just taking 2 puffs, right, like yesterday. But can it lead on to hypokalemia? We'll deal with that in a few minutes. No need to worry. The patient is also a known alcoholic. Alcoholism, there is no association with hypokalemia, my dears, but alcohol withdrawal might land up in hypokalemia. So we have 4 major concepts which are actually orienting us towards hypokalemic myopathy. Point number 1 is patient was suffering from diarrhea. Number 2, patient was given thiazide diuretics. Number 3, salbutamol therapy. Number 4, now currently in alcohol withdrawal. We'll be explaining that now, guys. We'll be explaining about every individual concepts regarding how every thing is going to be leading on to hypokalemia. Let's start with thiazide diuretics first. Let's start with thiazide diuretics. See, as per thiazide diuretics are concerned, name some thiazide diuretics which you know. Hypokalemia. I'm just looking at the messages right now. Dr. Pavitra, hypokalemia and hypercalcemia adverse drug reaction. You're right, Dr. Pavitra. Thiazide diuretics are associated with hypokalemia and hypercalcemia. We'll deal with that in a few minutes. I'm going to be explaining about thiazide diuretics now. We all know that this is your glomerulus, and we have proximal convoluted tubule. We have the descending limb of loop of Henle. Here is where the loop of Henle is. Thick ascending limb of loop of Henle. Distal convoluted tubule, followed by the collecting duct. Where all the different nephrons is going to be draining back. Now, where is the mechanism of action of thiazide diuretics? Thiazide is going to be producing the response in the distal convoluted tubule. We all know that. So what exactly is happening in the distal convoluted tubule? I'm going to be drawing that here, my dears. What is going to be happening in the distal convoluted tubule? See, consider here is where the distal convoluted tubular epithelial cell is going to be, and the left side is where the blood is going to be there, and the right side is where the urinary lumen is going to be situated. Clear? What's the mechanism of action of thiazide diuretics? It tend to inhibit sodium chloride symporter. On the other hand, what about loop diuretics? It will inhibit sodium potassium 2 chloride co-transporter. Why are they called as loop diuretics? Because they are going to be acting at the thick ascending limb of loop of Henle, whereas thiazide diuretics will be acting at the distal convoluted tubule. Now, here is where we have a transporter which is situated here, because of which there is going to be reabsorption. There is going to be reabsorption of sodium and chloride. Thiazide diuretics, whenever it is administered, is going to be getting filtered via the glomerulus. Thiazide diuretics is going to be filtered via the glomerulus. It gains entry into the loop, thereby it gains entry into the distal convoluted tubule. Now we have thiazide diuretics inside the lumen of the urine. Now we have thiazide diuretics inside the lumen. Thiazide diuretics tend to inhibit this sodium chloride symporter. Thiazide diuretics tend to inhibit sodium chloride symporter. Now what will happen? Sodium reabsorption is not going to be happening. So sodium is going to be moving along the urine output. So the patient might land up in hyponatremia. But where comes hypokalemia here? Remember that thiazide produces hypokalemia not by a direct mechanism. It's going to be an indirect mechanism. What exactly is that indirect mechanism, buddies? See, whenever the thiazide diuretics is acting up at the distal convoluted tubule, there is going to be more amount of sodium which is accumulated in the urine. Is that right? Yes, sodium is going to be extraordinary in the urine. When the sodium is going to be more in the urine, the body will try to correct that issue, because normally the sodium is getting excreted out. So here there is going to be more excretion of sodium in the urine. So the body will try to correct it out. How? By increasing the secretion, of aldosterone. By increasing the secretion of aldosterone. What exactly is aldosterone? It's a mineralocorticoid. What is the function of aldosterone? It takes in sodium from the urine. It throws out the potassium into the urine. Right? Sodium is going to be moving back into the blood. Potassium will be let out into the urine. That is the normal function of aldosterone. Now what happens? Because of secretion of aldosterone, there is going to be something else which is happening in the distal convoluted tubule and also in the collecting duct. Now here what happens, I'm going to be explaining what is going to be happening at this point at the distal part of the distal convoluted tubule. So what is going to be happening here? Again, we have the epithelial cell, we have the lumen here, and we have blood here. Due to increased amount of sodium, there is going to be more secretion of aldosterone. Now, aldosterone, as I told, is going to be taking in sodium from the urine because of ENaC, epithelial sodium channel. Because of it, sodium is going to be reabsorbed back into the blood in exchange with what, buddy? In exchange with potassium. With the help of rectified outer membrane potassium channels, ROMK channels. We also have a separate channel over here, and this channel is nothing but sodium potassium ATPase pump, SPAP. This is SPAP, sodium potassium ATPase pump. With the help of this pump, the sodium is going to be reabsorbed back into the blood and the potassium is going to be let out into the urine. Now, as I've told already, there is more amount of sodium which is there in the urine. The reabsorption of sodium is not going to be more because as I've told, extraordinary amounts of sodium. Even if you try to reabsorb that much amount of sodium, it's not going to be happening, because this potassium excretion which is happening is primarily dependent on this particular channel, that is SPAP channel. There is going to be development of saturation of this SPAP, because it is not only reabsorbing sodium, guys, it is going to be reabsorbing sodium in exchange with potassium. Because of saturation of potassium levels, the reabsorption of sodium is not going to be maximum, it's going to be minimum. That's the reason why we always say that thiazides are not high ceiling diuretics, they are medium efficacy diuretic agents. Forget about that medium efficacy. Let's come towards this case scenario here. What is actually happening? Because of potassium excretion which is happening, more throwing out of potassium into the urine will land up in hypokalemia. More excretion of potassium in the urine will produce hypokalemia. Understood? So with this concept in mind, we can understand that thiazide diuretics can indirectly produce hypokalemia. Loop diuretics can directly produce hypokalemia because they are sodium potassium to chloride cotransporter inhibitor. Potassium will be thrown out from the body by its own mechanism itself, but thiazide has got no direct relationship with potassium. It's going to be an indirect, beautiful relationship. Good. Now, what was the next drug? So what happened to calcium in the use of thiazide diuretics? I'm getting the question here by Dr. Tamil. Calcium levels is going to be, see, we have a separate channel called as TRPV, right? Transient receptor potential. TRPV channels, because of the action of TRPV, calcium is going to be reabsorbed back into the blood. No need to go into the deeper perspectives here. TRPV stimulation is responsible for calcium reabsorption. That is going to be stimulated by thiazide diuretics, leading on to reabsorption of calcium, causing hypercalcemia. Good. Now, that's the first mechanism of how thiazide diuretics is going to be associated with hypokalemia. Moving on to the second drug. What was the second drug? Salbutamol. What is the association of salbutamol and hypokalemia? What exactly is salbutamol, buddy? It is a beta-2 agonistic agent. It is a beta-2 agonistic agent. Now, understand this basic concept, buddy. We have a particular cell. It might be any cell which is present within our human body. In that cell, there is going to be a transporter. There is going to be a transporter which is situated. This is responsible for efflux of sodium and influx of potassium. Efflux of sodium and influx of potassium, which means normally we know sodium is an extracellular ion, potassium is an intracellular ion. Whenever a channel opens, if it is a passive diffusion, sodium must gain entry inside the cell and potassium must be moving out of the cell. But here the inverse thing is happening. Sodium is moving out and the potassium is moving in, which means it is a classical example of active transport, which includes energy molecules. And that's why this channel is also called as, again, SPAP channel. Sodium potassium ATPase pump. This is a sodium potassium ATPase pump. Now, this sodium potassium ATPase pump can be stimulated by two different mechanisms or intracellular mechanisms. If there is increased cyclic AMP, it is going to be stimulating this SPAP. Or if there is stimulation of tyrosine kinase, there is going to be stimulation of SPAP. Understand this. How cyclic AMP is going to be increased? We all know that cyclic AMP is a second messenger. It is going to be synthesized from ATPs, which is going to be converted by stimulation of adenylyl cyclase, which in turn is going to be there because of GES coupled receptor. So simply put, here we have a GES coupled receptor. 1, 2, 3, 4, 5, 6, 7. It passes through the membrane 7 times. So a GES receptor, which is going to be increasing the cyclic AMP levels, thereby stimulates this SPAP molecules. We have one more receptor or any receptor which is associated with tyrosine kinase on the intracellular area. Simply put, enzyme bound receptors. Intracellularly, this receptor is bound with tyrosine kinase. Now comes the next important query. Which GS receptor is going to be there, especially in the periphery? It might be muscles or in the adipose tissue. In majority of the areas, which GS coupled receptor is situated? We have one important receptor body, and that is beta 2 receptors. Beta 2 receptor is the GS receptor which is there in the muscles and also in the periphery. Which means on stimulation of beta 2 receptors, by what drug? Salbutamol. Good. By stimulation of salbutamol, what will happen? Beta 2 receptors will increase intracellular cyclic AMP, thereby stimulates SPAP, thereby what is going to be happening? Whenever you give salbutamol, it stimulates the beta 2 receptors, increases cyclic AMP, thereby stimulates SPAP, which leads on to more influx of potassium. Potassium from the blood will be moving inside these cells. As the potassium is going to be moving inside the cells, patients will land up in hypokalemia. From where it is going to be moving inside the cells? From the blood vessel. Good, super good. It's going to be moving from the blood vessel inside the cells. This is the reason why we always say salbutamol tend to induce hypokalemia, an important adverse drug reaction of salbutamol. Now comes the next important question. You remember that in that case, the patient was not on regular therapy with salbutamol, on and off therapy with salbutamol as on need basis. But here the patient has taken 2 puffs of salbutamol. We can say that the most important cause for acute onset hypokalemia, one important cause is going to be overuse or overdose of salbutamol. Even though the patient has taken only 2 puffs of salbutamol, it will not be clearly categorized as overdose, but due to additive mechanisms here, due to synergistic mechanisms, which can be seen with other drugs like, this thing which we have seen before, thiazide diuretics, there is more chance of hypokalemia, which can be expected. Now, what are the other adverse effects of salbutamol or beta 2 agonistic agents? You remember that there are 3 T's. There are 3 T's which are other adverse drug effects of salbutamol. The first T is there is association of tremor. We can expect tachycardia, heart rate is going to be increased. And the last T is tachyphylaxis. The response is going to be very much decreased, which can be prevented when it is given along with the steroids. Even though the beta 2 agonist induced tachyphylaxis as seen with bronchodilation is lesser, right? Which means what exactly is tachyphylaxis? When you give the first dose, the effect is good. When you recurrently use the same drug dose, the effect is going to be constantly diminishing. That is what called as tachyphylaxis. But for bronchodilation, the effect of the tachyphylaxis because of beta 2 is very leastly seen. Why? Because the bronchial smooth muscles are having abundant number of beta 2 receptors. The other actions of beta 2 receptors like vasodilatation or muscles or peripheral tissues or in the bladder smooth muscles or the GI smooth muscles. In all these areas, there is chances of tachyphylaxis, but bronchodilation tachyphylaxis is somewhat lessly seen. But anyhow, that tachyphylaxis also can be prevented if it is given along with steroids. Beautiful. That's it about this thing, guys. So what about the second one? We have one more tyrosine kinase, right? Which is going to be stimulating the tyrosine kinase. Name some receptor which is going to be, it's a peptide molecule which has got a tyrosine kinase associated receptor that is also associated with hypokalemia. Anyone, my dears? Anyone from the, anyone who can answer this question? The question is, we have a particular molecule which tends to bind with the receptor which is already having intracellular tyrosine kinase, thereby it also might induce hypokalemia. Anyone who can answer this question? Yes, guys, come on, fast. Yes, anyone who can answer this question? Which might induce hypokalemia, and the receptor is actually a tyrosine kinase receptor. Yes. Okay, I will just come up with the answer here. The answer is going to be insulin. Yes, insulin is the peptide which is going to be binding with the receptor, which is actually a tyrosine kinase associated receptor, which in turn is going to be producing more influx of potassium from the blood into the cell, leading on to hypokalemia. Good. Thank you. Now, moving on to the last one. We have seen that the patient was having diarrhea, right? The patient was having diarrhea for the past 3 days, which means we all know that in terms of diarrhea, there is more amount of water and electrolyte loss leading on to hypokalemia. That's a self-explanatory one. What about the last one? The patient was on alcohol, right? The patient was non-alcoholic for the past many years. And for the past 4 days, he didn't take alcohol because he was having diarrhea. He was having a fear like it might induce more amount of diarrhea. When a patient is on alcohol withdrawal, remember that when a patient is on alcohol withdrawal, when a patient is on alcohol withdrawal, or when a patient is in acute myocardial infarction, or when a patient has been diagnosed with theophylline intoxication, theophylline overdose, when a patient is in theophylline overdose, all these things might induce emergency stress response. All these things are associated with emergency stress response, which in turn might increase the levels of epinephrine release, which in turn might increase the adrenaline or epinephrine release inside the blood. Adrenaline, what are the receptors in which adrenaline is going to be working at? It will act at all the receptors of adrenaline, beta 1, beta 2, and beta 3. With all the receptors, adrenaline will tend to produce response, which means when the patient is on alcohol withdrawal, stress response is going to be stimulated, which in turn is going to be increase in the adrenaline levels. Adrenaline in turn is going to be binding with this beta 2 receptor, thereby increases potassium movement inside the cell, thereby increases the chances of hypokalemia. Understood? Remember that this type of hypokalemia can be seen only with adrenaline, my dears. It is not going to be seen with the noradrenaline. Why? Why? Because noradrenaline has got no beta-2 activity. Noradrenaline has got very less beta-2 activity. Noradrenaline will not produce. There is less chances of hypokalemia. On the other hand, adrenaline has got more chances of hypokalemia. This is the mechanism of how it's going to be looking like. Now, what exactly is the physiological mechanism behind adrenaline-induced hypokalemia, right? Why? Because see, always understand this. Yeah, hi Pravin. Hi Pravin. Thank you. So adrenaline. So the concept of adrenaline over here is, see, whenever you're exercising, right? Whenever you're exercising, the heart rate needs to be more because because we are increasing the blood supply. When you're utilizing your muscles, the blood supply needs to be more. We need to produce muscle or central organs vasodilatation. This is a sympathetic response. The brain will switch on the sympathetic response. So all the substances or all the organs which are supplied by the sympathetic neurons is going to be stimulated. The adrenergic neuron, which is supplying the heart, adrenaline will be released, which will bind with the beta-1, increasing the heart rate. It will also bind with the peripheral areas. It will also bind with the muscles, leading on to tremors and all the tachycardia, sweating. All these things is going to be happening there. But whenever there is muscle usage, there is going to be hyperkalemia because of increased potassium efflux from the cell. To prevent the heart from landing up in hyperkalemia, the sympathetic system will take over, guys. That is the physiological mechanism behind it. Exercise-induced hyperkalemia. Everyone knows that there is a concept called exercise-induced hyperkalemia. Exercise-induced hyperkalemia. This is a common concept. To prevent this exercise-induced hyperkalemia, we have a physiological blocker. We have a physiological blocker, and that physiological blocker is stimulation of sympathetic autonomic nervous system, which in turn is going to be increasing the adrenaline release. Adrenaline in turn will take up the potassium, put it inside the cell, thereby prevents the body from landing up in hyperkalemia. Sir, you were talking about potassium till now, but you have never mentioned anything about the ECG changes. Yes, there might be ECG changes. If you look into the ECG of this patient, there might be an abnormality. The height of T waves is directly proportional to the level of potassium body. Tall T waves represents hyperkalemia, whereas flattened or inverted or extra U waves is going to be explaining hypokalemia. Right. With these concepts in mind, we'll go back. Just give me 1 minute, guys. Yeah. With these concepts in mind, we'll go back to this history here. A 55-year-old male presented to the casualty with complaints of muscle weakness in extremities of both limbs. Past history, the patient was suffering from diarrhea for the past 3 days, known hypertensive for the past 10 years under hydrochlorothiazide, salbutamol, known alcoholic, but he didn't take alcohol for the past 3 days. So the provisional diagnosis is going to be hypokalemic myopathy. Hypokalemic myopathy. How can we treat this patient, buddy? Simple, administer potassium chloride. You administer pot chlor, potassium chloride syrup is going to be regaining back the potassium levels. Now, what are the other drugs which might be inducing? What are the other drugs which might be inducing hypokalemia? We have a mnemonic here, buddy. A, B, C, D, V, I, T. A stands for ampicillin, adrenaline, amphotericin B. B stands for bronchodilators like the beta-2 agonistic agents. C stands for chloroquine, cisplatin. This is an important question. Chloroquine and cisplatin are associated with hypokalemia. Corticoids. What are those corticoids? Corticoids includes mineralocorticoids, which defaultly produces that we all know, right? What's the function of aldosterone? Takes in sodium, lets out potassium. Mineralocorticoids are associated with that. Corticosteroids, like your glucocorticoids, are also associated with hypokalemia when given at high doses. When given at high doses, glucocorticoids also are associated with hypokalemia. D stands for diuretics. Both loop and thiazide diuretics tend to produce. Loop produces direct hypokalemia. Thiazide produces indirect hypokalemia. V stands for verapamil, calcium channel blockers. I stands for insulin. We have explained the mechanism. T stands for theophylline. So now comes the next important question, right? How come verapamil and theophylline are associated with hypokalemia, which can be explained in one more clinical Thursday, guys. With this, we finalize today's session, buddy. I thank you so much for all those guys who are who have responded. Thank you so much, guys. If you have any queries, you can just contact me at any point of time. Good. Thank you so much, and bye-bye. Thank you, Dr. Vanilla, Dr. Samrat, Dr. Pavitra, Dr. Tamil, and Dr. Pravin. Thank you so much.